Another question is where to place the non-covalent BTKIs, because it's a fantastic drug, very well tolerated. Do we have to use covalent, then venetoclax combinations and spare the pirto in third line, or move forward the pirtobrutinib? Susan, what do you think?
It's difficult because the safety profile of Pirto really looks good, and I think it does look better than the second generation BTKI. But we know, number one, that if a patient can tolerate a covalent BTKI, they can get very, very long remissions. I mean, remember on Resonate 2, the median PFS was like 9 years. And that was ibrutinib, but I think it's reasonable to extrapolate to the others that you can get very long remissions. That doesn't mean you can't get long remissions with Pirto, but of course we know you can use Pirto after the covalent inhibitors, and what we don't know is can you use covalent inhibitors after Pirto, or will using Pirto first then knock out covalent inhibitors as an option? All of these unknowns are an issue. I think for me, where I might consider using it upfront right now is a really older patient where I'm not worried about sequencing. So in fact, I had one the other day who is 90 years old. I don't have many of them, but a few, probably everybody does. And he finally needed therapy. I put it off as long as I can. And I thought, well, now this is the kind of patient I would probably go straight to Pirto. I'm not worried about what he's going to need second line. But I think in patients who are not that old, even in an 80-year-old, for example, I might be willing to do Pirto first line. Depends what your cut point is for where you think maybe I'm not going to need a second therapy. But if I think I am going to need a second therapy or I have a much younger patient, I would be doing fixed duration anyway. I wouldn't be doing continuous BTKI.